Good afternoon, everyone, and thank you so much for joining us for another edition of Kidney Talks with the GW Ron and Joy Paul Kidney Center, MOTEP, the Minority Tissue and Transplant Education Program, the Pennsylvania Avenue Baptist Church, and of course, BlackDoctor.org. I'm your host today, Suna Halley, and I'm a program manager at the GW Liver and Pancreas Institute for Quality. Our panelists for today are no strangers to the show. We have Dr. Clive Callender, who is professor of surgery at Howard University College of Medicine and the founder of MOTEP. We also have Dr. Keith Melanson, who is the chief of the GW Transplant Institute and professor of surgery at the George Washington University Hospital. Today's webinar will be focusing on COVID-19 in patients with kidney disease and kidney transplant recipients. Our presenter for today is Dr. Huda Gasmelseed, and she is assistant professor of medicine at Howard University College of Medicine. She is also an associate program director for the internal medicine residency program at Howard University Hospital. She also has extensive experience working internationally for the response to COVID-19. Without further delay, I would turn it over to you, Dr. Gasmelseed.
Hey, thank you so much for the nice introduction. Yeah, so I'm a little bit excited to be here with you all today. And I will just go ahead and with my talk, I would like to highlight the impact of COVID-19 infection on patients with kidney disease and kidney transplant recipients. Can we move to the next slide, please? Next. Yeah, I don't have any financial relationship. And my talk will be highlighting, as I mentioned, the impact of COVID-19 infections in patients with kidney disease and kidney transplant recipients. I will highlight the incidence during the pandemic, the mechanism of acute kidney injury, and the role of a gene called the APOL1, which is the apolipoprotein gene that has been associated with kidney injury in patients with infection of COVID infection. So also I will also highlight the reinfection rate, the long COVID, and about talk briefly about the prevention strategies. Next slide. As we all know, the coronavirus 2019 infection emerged back as a pandemic in December of 2019. It did spread rapidly across the world and caused a global pandemic in only 3 months. And this pandemic has transformed life throughout the globe and affected the medical community. So our patients have been affected, especially immunocompromised patients who are like kidney transplant recipients, patients with chronic kidney disease, and other underlying chronic conditions. Next slide. So patients with existing kidney disease has been quite challenging because they are high-risk patients where they can develop severe infections, complication, and even death. So patients with a chronic kidney disease are considered part of this high group patients. And the widespread lockdowns have affected the delivery of healthcare to these patients, as well as delays in dialysis, patient on already hemodialysis, and patient who has been on the transplant list has also affected significantly, where we have seen a higher mortality during that time. So the pandemic did has reinforced the need for accessible home-based therapies, like patients who are on hemodialysis that can be transitioned to peritoneal dialysis, and also highlighted the value of telecommunication, telehealth, and teleconsultation. Next slide. So, in the early stage of the pandemic, we have noticed a significant number of acute kidney injury, and about 30% of those patients who were hospitalized to the medical ward. However, there was significant number of patients who had a higher mortality in the ICU, and we have seen up to 50% of those patients in the ICU require dialysis. Next slide. Having said that, the incidence had did decrease over the pandemic period, and there is one study from multiple hospitals in New York City. They found that the AKI, the kidney injury, has been up to 29%. However, the rate of the kidney injury and patient requiring dialysis has reduced significantly during the pandemic. And I will explain in my next slide, please. And that has been contributed to improve recognition of the disease itself. We have more therapies like antiviral medicine. We have availability of ICU beds. The vaccine rollout also played a significant role in the reduction of kidney injury. And at that time, also we had transmission of less virulent strains, for example, as the Omicron. Next slide, please. So the mechanism of the kidney injury has been multiple. It's so complicated. I just wanted to simplify that the kidney cells, they have receptors where the virus can attach to, invade the cell, make copies, and by doing that, it damages the kidney cell. Also, the same receptors are found in other parts of the body, like in the brain, the kidney, the heart, and the lungs. The other factor that has been also found that with COVID infection, patients have low oxygen in the blood, and that have contributed to also like kidney damage. Next slide. There is something called the cytokine storm. It's a medical term, but it's a kind of immune dysregulation where the body will try to attack the virus by producing certain proteins called the cytokines. Because of the tremendous infection, we have a lot of these cytokine inflammatory cells that can also attack the kidneys and can cause problems. The other hypothesis of the mechanism of the injury is mainly having a blood clot, and those clots can also clog the kidneys and cause kidney impairment. Certain patients with kidney disease during COVID, they had kidney biopsy. What the researchers found that those the pathology, it's like something called collapsing glomerulopathy, which is mainly collapsing of the tissues of the kidneys. Can you go to the next slide? There is a strong association between a gene called the apolipoprotein 1 gene and the collapsing of the kidneys and patients with COVID. It's a kind of a gene that has been identified previously as a kidney risk gene in certain populations. And these have been identified in persons of African descent, in particular descendants from West Africa. So in April of 2020, several case reports described the collapsing glomerulopathy in patients with COVID-19 infection. Next slide, please. So, further to prove this, there is a big study that has involved about 990 participants with African ancestry enrolled in the Million Veteran Program, who were hospitalized with COVID-19 between March of 2020 and January of 2021. And their genetic information was available at that time. So in this cohort study of veterans with African ancestry, they found that there is like a strong association with patients who have this gene and the severity of the kidney disease, and actually that has also increased the mortality and death in that particular patient population. They also found that people who have this gene who comes in with a normal kidney function also did very poorly and with a higher risk of kidney injury and death. Next slide. So Patients who have like kidney transplant recipients also has been affected, and we all know that the pandemic has significantly changed the landscape of kidney transplantation. It did impact the patient themselves, where they have higher mortality, as based on the studies. Patient waiting for transplantation also has been affected, and in one study, it found that patient transplantation has been reduced down to 50% nationwide and maybe across like internationally as well. So all affected all aspects of transplant care, including the transplant referrals, listing, organ donation, shipment, and patient waiting for, as I mentioned earlier, waiting for the transplantation had a higher rate of mortality. Next slide. Multiple published data did show a higher mortality between 20 to 30%. However, they didn't mention the time of transplantation. I found only one large study from France that has evaluated this, and patients received within 1 year has been associated with higher mortality as compared to patients who are more than year out from the transplant. Next slide. So, can patients with kidney injury and COVID infection recover? So, this depends on multiple factors. So, if the kidney injury happened without patient requiring dialysis, probably this has a better outcome. However, patients who are requiring dialysis are more likely to die than patients without dialysis. And studies have shown that people who survive, around one third with will gain will not gain any kidney function improvement at the time of discharge. So definitely they will end up with like a chronic kidney disease. Next slide. So, what about COVID and reinfection? Can it happen? Absolutely, yes. Even in vaccinated patients and who have a booster. So, there is increased risk of severe disease and subsequent COVID infection. And actually, studies have shown even the death rate has with reinfection has increased. So, in people who have already had the COVID-19, the recommendation now is to try to prevent reinfection. Next slide. So there is another study showed is also from the VA. It included about 5.8 million records that has been reviewed just to see if there is any increase of organ damage, including kidneys, and what about the mortality. Next slide. So in this research, they found that patients with COVID reinfection were twice as likely to die and 3 times more likely to be hospitalized. Also found 3.5 times more likely to develop lung problem, 3 times to have heart condition, 1.6 times to have a mental health issues and brain conditions, and also increased risk of diabetes and kidney disease. Next. Now, the long COVID is a new term that multiple, like there is one a big clinical trial involving patients, and usually with people with COVID infection, they usually recover within few days up to few weeks. However, found that patient who may have longer like symptoms may stay longer up to weeks or months or years, and this is the term called long COVID, and has other names as well. It is a long COVID, long haul COVID, post COVID. So all these are the same term for the same condition. Next slide. So, what are the symptoms of long COVID? So, it's multi-system involvement. Patient will have extreme fatigue and not feeling up to exercise. They may have shortness of breath, chronic pain, difficulty sleeping, racing of the heart rate, stomach, lung, kidney, and heart issues, memory and concentration problems that may make it difficult to perform well at work or school. The long COVID can also trigger other health conditions like diabetes, as I mentioned earlier, and kidney disease. And there is emerging data indicates that getting vaccination may help prevent long COVID. Next slide. So in early 2021, the NIH conducted this RECOVER trial, involved all patients with this symptom that we just mentioned, and they would like to look what have contributed to this and how can we treat long COVID infection. Next slide. So coming to the prevention, definitely the general, preventive measures like, hand washing, masking, social distancing, avoiding crowds, and vaccinations. We have to remember that all transplant recipients are eligible for vaccination unless they have a hypersensitivity reaction to the vaccine or its components. So in August 2022, the CDC issued more relaxed COVID-19 guidelines for many Americans, and the revised COVID-19 guidance places greater responsibility for disease prevention on individuals. But the guidance for the immunosuppressed patient has not changed. Next slide. So, in summary, the COVID 19 pandemic has been one of the worst infectious disease crises in our century and affected healthcare globally, particularly for people with pre existing kidney disease and definitely with patients with kidney transplant, and higher risk of adverse kidney outcomes in individuals carrying the APOL gene. And patients who are getting vaccinated may help prevent the long COVID symptoms. And this pandemic reinforced the need to move away from physician and healthcare facility-based models of healthcare delivery and highlighted the value of telehealth and remote monitoring technologies. It also underscored the need for consistent communication from the local, state, and federal governments and has identified striking global inequities in the care of patients with kidney disease. Next. And these are my references. And then I will be happy to answer any question that you may have.
Thank you so much, Dr. Gasmelcy. That was so informational. And I know that our audience has gained a lot of knowledge from your presentation. So thank you so much. We'll open it up to any questions that come from the audience, but I know I wanted to start off with one based on your presentation. You mentioned that there's a kidney risk gene, the APOL1, which is kind of how someone would determine, if they're at risk for the COVID-19. How would a person learn about this, or how would they get tested? What type of test would determine that, and what doctor would a patient see?
Yeah, this is an excellent question. There is no routine testing for this gene. However, because it's a combination of this gene, patients who have other comorbidities like high blood pressure, diabetes, that may increase the risk of kidney injury with COVID infection. In the general population has been associated with acceleration of kidney disease and kidney failure, but there is no routine testing. But I think maybe if there is certain areas, like a genetic studies, maybe they will run it as well. But to my knowledge, I don't think it's a routine testing.
Gotcha. So I'll open up the conversation to Dr. Calendar. Please weigh in. We've talked and heard a lot about the effects of COVID-19 for kidney patients. What have you seen in your practice?
I think this is a fascinating presentation. Thank you so much. Uh, and I love your question about APOL1 because we've had a lot of interest in that and
Mhm.
with kidney disease and transplantation. And it's a genetic test that, as she said, is not going to be done unless your physician actually asks for it. And, uh, and it's important for at least the community to understand that there is this gene that protects against sleeping sickness. But the side effect of that gene is that it may uh, result in us being more likely to get kidney disease. And now, in this instance, we also are more likely to get kidney disease from COVID, which is something that is remarkable. And I thank you very much for pointing it out. But the thing that I was going to ask as well is when you said acute kidney injury, what does that actually mean from your perspective? When you say somebody has AKI, what does that actually mean?
Yeah, it's mainly like a dysfunction of the kidney. And mainly what we do, we do a blood test, and that will show some increase in the kidney function. Sorry, a decrease in the kidney function with high numbers, like something we call the BUN and creatinine ratio, or the BUN and the creatinine will go up, and that's mainly the kidney dysfunction. And as I mentioned, the mechanism is several, including the virus attacking the kidney itself versus the oxygen low in the kidneys and other factors as well that can cause the kidney injury.
I wanted to ask you before Dr. Melanson gets in, because I'm anxious to do it. You've had an international experience. So
Yes.
tell us, how does it differ from your experience in the Middle East and what you've noticed here in the United States
Yeah.
with COVID?
So yeah, sure. So during COVID, I was already practicing the Middle East, and then I was there during the lockdowns, and we created um, the protocols and the procedures. What is different from the United States? The country that I was working at was United Emirates, um, like the Emirates, and it's a wealthy country. And what they did, all patients coming to the airport are screened regardless, and they put on isolation until the test is out, just to, yeah, that was extreme to me. So was like really, initially they were able to contain the infection, and but then definitely when the pandemic accelerated, they were not able to. That's the only difference. But everybody was tested, everybody was treated, regardless with symptoms or without symptoms, as contrast with the other parts of the world.
Mm, wow. Everybody is treated equally.
Yeah, exactly.
Dr. Melanson, please weigh in. What have you seen in COVID-19 in our kidney transplant patients?
Yeah, first of all, Dr. Gazmaseed, what a great presentation and
Thank you.
timely. Even though things have gotten so much better, um, I was having all those the horrific memories coming back as you were speaking, because we had a lot of issues here. But thank God it wasn't as bad in this region as it was just north of us in New York. But we did have lots of issues. Um, First of all, about what you said about ApoL1 is absolutely true, and Dr. Callender spoke about it as well. We do offer, and I think most of the transplant centers, if you can offer ApoL1 screening to patients, because there's a commercial kit. It's called Renasight, where you can just have the test done on any patient, and ApoL1 is just one of the all of the genetic stuff that you can get. So we can run those for patients. Um, but here's my question: given all of the controversy in this country about the vaccine, do you know of any correlation of the actual vaccine with kidney injury rather than the COVID infection itself?
I didn't come across any study mentioning that, and no, I haven't come across anything.
Yeah. And I know that there is, I mean, particularly if you go on the internet, there's so many stories of people having problems with the vaccine. And, just never in my career have I seen such just misinformation being exploited the way this stuff about the vaccine has been. And it continues to go on, which is just so problematic. Um, but here's my next question, and it's ironic because I'm actually going to UAE next week, so
Okay.
I'm going to be in the country where you were. But in comparing what they did there to what we did here, where we had such a problem with testing earlier, what do you think? And again, this is probably there's no right answer, but I'm just wondering, what do you think we could have done differently in this country that may have decreased all of the deaths? We lost, you know, millions in this country, and I think that maybe something could have been done differently. What do you think? There's anything we could have done short of getting the vaccine earlier?
Okay, so actually it's quite difficult because at that time we have very like a variant strain, and it's not only here in the United States we have seen the high mortalities across the board. Even in my hospital, when we had patients who were admitted to the ICU, our death rate was quite high, and it's comparable to the United States. I think the variants of the virus itself, with time, became less virulent. Maybe. I can't imagine how faster we can get a vaccine less than a year. So any kind of vaccine, I think it was appropriate within 1 year to be tested, and then they just, rolled out. Yeah, but anything to be done differently except about the social distancing? What wasn't that strict maybe here in the United States as compared when I was there, maybe? And patients were not like, we are not doing mass testing. Everybody was simply, they just isolate, and it wasn't restricted.
Awesome. We do have a question from the audience that's a little unrelated, but we do like to answer questions from our audience members because a lot of them, this is their opportunity to get an answer, or will also encourage them to go and see a physician. So the question we're getting from the audience is about kidney disease and dialysis. Sorry. Is it possible to reverse kidney disease if you are on dialysis?
Well,
Dr. Calvin.
well, if,
Uh,
we get that question often, and
Yeah.
it depends upon whether you have acute kidney injury, as she spoke about earlier, or whether you have chronic. If you have chronic disease, then it's not going to be reversible. But if you have acute kidney injury, in 90 to 95% of the times, it is reversible, and it will go away within 6 weeks to 8 weeks if it's acute kidney injury, depending upon what caused it. Because acute kidney injury means that it's reversible. But if you have chronic disease, that's not going to happen.
I can add to that because patient with COVID, they may have this acute kidney injury, but some of them may develop chronic kidney disease and dialysis eventually. So there is a risk. Some of them may recover, some of them may not.
Awesome. All right. Thank you so much for answering that. I do have a question related to reinfection for COVID-19. Um, do we have any data that supports reasons for reinfection and just the severity of organ damage that may come from that based on your presentation?
Yeah, so there's some studies have shown that, as I mentioned, from the VA, the data has been pulled, and they checked the reinfection rate, and they found a higher mortality, higher progression to kidney disease, a patient with multiple reinfections. So it's will be more if a couple of times, 3 times, or more than 4 times, they have highly likely to get kidney disease and death,
Okay.
and severe disease. Yeah.
And just for the general public, for COVID-19, it's 2023 now. Do we know what causes or what are some contributing factors to COVID-19 that will increase your risk? We have heard the traditional staying 6 feet and using your mask. From I would like everybody on the call to answer professional experience. How can we reduce the risk of COVID-19?
Oh, I will again say the vaccinations. I
Okay.
know, yeah, the vaccines will wane off. Maybe I think maximum they say that's why they're going to make it like an annual vaccine, like the flu. So, yeah, that's the only thing that I can think about in addition to the other measures.
One of the things that people talk about even now, right now in all hospitals, masks are optional.
Mm-hmm.
But it is true that if you wear a mask, that it may be protective. The question uh, is it a stigma? Because everybody else has no mask. So if you put on a mask, how does that affect others, and what is their relationship with you? You may be protected from the virus, but you're not going to be protected from the social outcast stigma.
Mm-hmm.
So that, and I have a group that we discussed this, and I go to basketball games, and when I go to basketball games, up until very recently, I would often be the only person with a mask on. For example, when you go to the airport, it's not the airplane that's the problem; it's the airport because the airport has the inhalation precautions on the plane itself, but it's walking through the airport. And so the question is to you, Dr. Gesmelseed, what are your thoughts about the role of continuing to wearing a mask and on when you're inside? What are your thoughts about it?
Yeah, actually, in the hospital, I wear it all the time, regardless.
Hmm.
Seeing patients in the clinic, but the moment I'm out in the parking lot, it's out.
Yes.
So I totally agree. Yeah, I traveled recently. It's still, in the airport, I couldn't wear. Everybody was without a mask, so even in the plane, so I have to take it out. So it's a little bit risky. I
Hmm.
remember last year, it was less COVID, and again, there was relaxation, the masking. I got sick. It was just like a common cold. It wasn't COVID because I tested negative for COVID. But again, I think the mask will help us reduce any kind of respiratory viruses, especially in winter. We have multiple. We have seen a peak of the RSV. It's a kind of virus that causes some respiratory, problems in immunocompromised and patient with COPD and lung disease. So we have seen a peak. COVID did go down, but the RSV did go up. So I think it's very challenging. So there is no good answer. So if somebody coughing, sneezing close to you, wear a mask.
I was
Yeah,
just, yeah.
yeah, I would agree. To me, it's inconceivable that a sick person will put themselves in a public situation, but you see it all the time. I was at a restaurant just actually this week, and the person sitting right next to me at the next table was just coughing and sneezing,
Mm.
and I just couldn't understand why do you go to a restaurant if you're coughing and sneezing?
Yeah.
I asked to move, but I mean, it's the world we live in, right?
That's
But absolutely, I carry my mask everywhere. I wear it in the hospital, definitely in the airport, and when I travel. But the what I would say is that everybody needs to understand COVID is still a problem. We've had two people here in my office who've recently had COVID infections. So even though things are less stringent than they used to be, and
Yeah.
thank goodness we're getting back to some sense of normality, this is still a deadly infection,
Yeah.
even for people that have been vaccinated.
Yeah.
Although the vaccine is the best way to stay alive after the infection. So I think we need to continue to hammer home the fact that the vaccine continues to be important along with all the boosters, and that we all need to have our masks, even if we don't wear them all the time. We should have them to wear them in specific situations, and we need to encourage people not to go out when they're sick.
Now, another thing is the fact that after 6 months after you've had the vaccination, it's time to get another shot. And some people don't realize that even now they had the vaccinations in November, and it's time now for second booster. So that we need to get that word out, because I've spoken to people recently who didn't know that it's time to get a shot. And then, you had already mentioned, it's going to be an annual requirement subsequently.
And Dr. Calendar, great point there. We actually have an audience question related to booster. So I'll go ahead and ask everybody on the panel here. If an individual is getting another booster shot for COVID, should they be tested for any antibodies? Is that necessary?
My answer would be no. After 6 months, get your booster, get your additional booster shot. You need it.
yeah. Initially, we were doing the serology testing to see if people are immune, but now we're not doing that anymore. We just go
Okay.
ahead and give the booster shots.
And so what is the time frame? I know we did 6 months after the initial. Now that we're, post the second or the first booster, what is the time frame to the third booster shot between the second and the third? Is it still 6 months? Is it a
6 months.
year? 6 months? Okay.
Mhm.
So you should be getting a booster at least every 6 months, correct?
No, after completing the first series means first dose, second dose with a booster. This is a complete series, and
Mhm.
then the fourth one, I think, yeah, after 6 months, and then maybe the annual. So a full
Annual.
series will be immunocompromised up to 4 doses.
Awesome. Thank you so much. So we do have one more question from the audience. Let's see where it
The
is
other
at.
thing is that keep in mind that, as you had mentioned earlier, the immunocompromised patients, we are not sure
Mm.
exactly whether or not all of them are able to respond to the vaccine. And therefore, uh, particularly in the immunocompromised patient. They need to get that vaccine after 6 months.
Can I add one thing? I recently got an award, like a grant, to study this. So I'm going to study patients who have kidney disease, received the full COVID series, and admitted to the hospital with COVID infection. I'm not doing a serology, but I will look into the database like nationwide, all patients who have COVID infection and has received the hepatitis B vaccinations. I want to put hepatitis B vaccination as a surrogate marker. If they mounted the immunity to Hep B, probably they mounted immunity to COVID infection. So I'm looking forward to this study, and maybe I can share with you once we have some data.
That's necessary, and I feel as though everyone will be looking forward to it.
Yeah,
So we have to come back and share it on BlackDoctor.org also. That would be great.
absolutely. Yeah, sure.
Okay, so we do have two more audience questions. In the meantime, when they're getting up, let's see. This one is from Teresa. Are there any kidney lab markers that can show if there has been kidney damage after prior COVID infection? Symptoms for kidneys can be silent until sometimes too late. Dr. Melanson, would you like to answer this one?
Yeah. So if you are going to have issues because of the COVID infection, usually it's going to create an AKI that we were talking about. And she's right, Mrs. Rawls, Bolden Rawls. You are correct that sometimes kidney problems can, in the first couple of stages, can be silent, but AKI is a pretty acute sort of issue. So when you're sick, the caregivers will notice that your kidney function has markedly decreased. It's those patients who are the COVID is actually affecting their kidneys. One of the things that we didn't know early on in the epidemic and the pandemic was that were patients who actually died with COVID infections or even died of COVID infections, were they safe to be donors? And now we know the data shows us that they are absolutely safe. Um, so even if a person dies of COVID related pneumonia or lung fibrosis with normal kidney function, we use those kidneys all the time for transplant now. It's pretty routine. So it's only a small segment of the population who will get the AKI that's associated with COVID. And it's those patients that need to be followed up. So like Dr. Callender said earlier, AKI will get better or can get better. But the question is, how much damage is left behind? And it's in those patients that develop the problem with their kidneys when they were severely ill, because you normally are severely ill if you have the AKI. Those patients need to be followed up to see if their kidney function goes all the way back to normal.
Dr. Melanson, every time you talk, I learned something new. I didn't know that transplantees or recipients COVID-19 you could still receive an organ, which is great because there's a lot of people on the transplant waiting list. And so here's a selfless plug: if you're not an organ donor, you need to become one and save a life. So everybody, make sure that you are an organ donor.
Yeah, so much again. Since I've been looking on the internet and trying to fight against the misinformation.
Hmm.
One of the things that happened to us, even specialists like Dr. Gamelseed and others, infectious disease doctors, this was a totally new thing.
Yeah,
This pandemic and
yeah,
this virus behaved in a way that we had never seen before.
yeah,
So a lot of the misinformation is they want to compare it to measles or
yes,
well, this is a whole new virus and it behaved differently, and we
yeah,
didn't know. I mean, how do you know about a disease? It's like the Black Plague comes about and people are making fun of doctors because they didn't know how to treat it. Well, I
yeah,
mean, it was the Black Plague. Now we know what to do to
yeah.
decrease that, and it's the same thing with COVID. So we had to learn. So one of the things that we learned, other than being able to use the organs, is if you came in and you were positive for COVID, and even if we called you from home, you had no symptoms, you came in, you were positive for COVID, we used to just send them home. We didn't do the transplant because we were so afraid that with
Yeah.
the medicines for transplant, they were gonna possibly die. We don't do that anymore either. Our ID colleagues can actually do counts on the virus
Mm,
to determine if how old the infection is. And those patients, we now transplant them all the time, and they do very well. But we had to go through the
yeah,
process of learning. It was a
yeah,
trial and error sort of thing. So that's why we know so much more
yeah,
now than we did. But the beginning stages in any sort of public health scare is to be cautious and
yeah.
conservative. So I think what we did in the beginning was the right thing to do, like Dr. Gamelseed said, which is, mask up, socially isolate, and be careful.
Yeah.
I think Dr. Gamble said that a third of the patients who had COVID turned out to have acute kidney injury.
No,
Is
at
that
the time of discharge,
a large number?
yeah, it is.
Very large. And I love this information. And audience, you're just so lucky to have this panel here today, because you are going to take this information and share it with someone else, because it's very important to understand. Just like what Dr. Melanson said, we're sitting in a good place where we know more about COVID-19 than we did in 2020. So when you're hearing suggestions and information presented to you, share it within your communities. This is the source of the information that needs to be shared, so everyone knows that we're moving towards the direction that we need to. Okay. I believe we have one more question from the audience, and then we'll open it up for last remarks. Oh, so, just in general, I'll start with you, Dr. Calendar. So now that it's 2023, and someone has kidney disease, what is their next steps if they develop COVID-19? Should they go and see their nephrologist? Should they be at the dialysis center? What is the next step if somebody does develop COVID-19? Is it treated differently, or do they still go into an emergency department?
Well, especially if you are immunocompromised, because it's clear, and I guess Dr. Gamelseed will answer this better than me, is that we now have, the beauty of what has happened because of research is that we now have treatment for COVID. We have treatment, not in addition to the vaccination. If you get COVID,
Mhm.
Dr. Gamelseed can talk about the way you treat somebody who is
Yeah.
now COVID positive and has inf- symptoms of the disease. You want to tell them how you
Yeah,
take care
sure. Actually, initially, I included this in my presentation, but I thought it's a bit complicated, so I took it out. But definitely, we have very clear guidelines are based for the treatment of COVID infection. So it depends on the severity. Is it a mild, moderate, or severe symptoms that patient requires an ICU admission? So definitely, we have remdesivir, which is an IV medication. Patient without any pneumonia, we give it for 3 days. Patient who have pneumonia, we give it up to 5 days. In addition to steroids. Just remember that the steroids is the only medication that had improved mortality in patients with COVID infection, not the antiviral, nothing else based on on the clinical trials. So mainly dexamethasone, we give it 5 days up to 10 days if somebody in the ICU. So for transplant and immunocompromised patients, again, we do some imaging, depends on their symptoms and on their labs. And based on that, then we tailor the treatment based on their stage of infection.
Wow. Thank you so much. So go see your doctor. Go and see your
one,
doctor.
one thing you mentioned in your talk was about the role of
Oh,
teleconsultation. Can you tell us how that impacted your practice? Is it good or bad, or
It is very good actually, because some of the patient, they may have the COVID symptom. They don't want to come to the office to see you, so that gives them some flexibility. And like transportation, especially immunocompromised, and once they leave their home and a little bit anxious, they may get the infection. So that offered like a great opportunity for them. We communicate, we talk to them, we advise them, send their medication to the pharmacy or deliver to their home. So it did help significantly. And I think even now, all the insurance companies are approving any kind we can bill for telehealth. So it's not like it will be denied. So that's a significant thing, and it's going to continue even after COVID.
all right. Well, we'll start with you then, Dr. Gasmo C. Do you have any parting advice or information that you'd like to share with our audience, or charges for them going forward?
What kind? Sorry, if you can repeat the question.
I was saying in
Uh-huh.
conclusion, if you have any final information you'd like to
Oh,
share with our audience or any charges to them going forward.
oh yeah, absolutely. So yeah, I think COVID eventually, it will be like a normal infection, like seasonal flu. It will get milder, especially when all people are vaccinated. Just continue with the precaution. Again, sick people around you. Try to avoid any contact with sick contacts. Do your exercise, healthy food, take care of yourself. Definitely, you will be in good shape. And
Thank
if
you.
you're sick, yeah, talk to your doctor.
Awesome.
I would also request, I think Dr. Melanson made a very excellent point, although he didn't pursue it. And that is that if you have a cold or something like that, put on a mask if you're going to go out. It's preferable that you stay home. But if you're going to go out and be in public, put on a mask yourself and protect others from you. And I think that's something that we don't, we don't want to, we don't want to tell them that you're doing the wrong thing, but let's tell them, hey, stay home if you're sick. If
Exactly.
you are sick and you go out in a public place, put on a mask.
Right. And so for my last words, first of all, I'm going to agree with what the wise Dr. Callender just said.
Mhm.
Um, and, I think the other thing to tell people today, because, we know so many people that have had COVID and they've gotten better, or they were sick, they stay home for a couple of days and they get better. But I think it's important to understand that a lot of the really bad complications happen when people get very sick. If you're getting sick, that's what Dr. Gamelseed is talking about. Those are the patients that need to come in and get antiviral therapy, steroid injections, because this, particularly the steroids, it can be life saving, and the antiviral therapy can really shorten the course of the infection. And it's a lot of the bad complications come from the people that get very very ill. So yes, lots of people get COVID, they get better, and it's not that big of a deal. But if you are sick, if you're really sick, even if it doesn't feel like, oh, do I really need to go to the hospital? The answer is yes. Go in and seek care and let the physicians decide, if you need to be admitted, if you need to receive antiviral therapy, so on and so forth.
Yeah, one of my best patients died of transplant patients died of a reinfection of COVID. And so the immunocompromised patients, and when we say immunocompromised, that means people like me who are over 70 years of age, and people who have kidney disease, as she had already mentioned, and people who are transplant. But it also means cancer patients and patients who receive medications that knock out the immune system. Those people are very, very subject to getting reinfected and also dying or having other serious complications.
Thank you so much. What an awesome, awesome topic and very timely. So thank you, Dr. Calendar, Dr. Melanson, and Dr. Gasmo Seed for presenting and providing this information to our viewers today. Um, and we have a thank you from the audience. Thank you, panel. We are very fortunate because the VA doctors community has been left far behind with a lot of this information. Oh, that's awesome. So this is a repeat of information then. So, everyone, thank you again for logging into this edition of Kidney Talks with the GW Ron and Joy Paul Kidney Center, MOTEP, the Minority Tissue and Transplant Education Program, the Pennsylvania Avenue Baptist Church, and of course, BlackDoctor.org. We look forward to talking to you again on the second Friday of next month. Have a great day.